concerning perioperative care. Summing up, this topic is equally important and I guess more important because it generalizes the patient outcome, improves the safety, and also guarantees or ensures that the patients have good quality. So to chair the session of perioperative care, I would like to request Professor Dr. Maya Lama and Professor Dr. Rohini Sigdale to come up on the dais, please. Professor Dr. Maya Lama is highly respected professor of anesthesiology at Pokhara Academy of Health Sciences with more than 3 decades of rich clinical, academic, and research experience. Over the course of her distinguished career, she has played a pivotal role in advancing anesthetic practice, and she is also one of the most pioneer anesthesiologists of Pokhara. Her special interests lie in pediatric anesthesia, obstetric anesthesia, and she has consistently demonstrated excellent patient care, safety, and evidence-based practice. Professor Dr. Rohini Sigdale is the head of Department of Anesthesiology at Pokhara Academy of Health Sciences and an accomplished anesthesiologist with 15 years of dedicated clinical and academic experience. She has published more than 10 articles in peer-reviewed journals and actively contributes to the departmental leadership, teaching, and research initiatives. She is committed to advancing the perioperative care standards and fostering innovation and skill development among trainees and colleagues. Now I'd like to hand over the mic to the chairs to introduce the speakers. Thank you.
Okay. Good afternoon, all. So now we have the first speaker for the last scientific session, perioperative care. That's our first speaker is Dr. Shobha Dongol. To begin this session, it's my pleasure to introduce our first speaker, Deputy Superintendent of Police, Dr. Shobha Dongol, Assistant Professor at the Nepal Armed Police Hospital, with over 6 years of academic and research experience and multiple publications in reputed peer-reviewed journals. Dr. Dongol has significantly contributed and is contributing to advancing perioperative and ethical care practice. She has received the UN Peacekeeping Medal and the Mahatma Gandhi Scholarship Award. So today she will be presenting to us the topic, burnout among anesthesiologists, the hidden cost of vigilance. We welcome Dr. Shobha. Now over to you.
Good afternoon, ma'am, and everyone. Thank you for your generous words, and thank you everyone for keeping up until the last session of today's SANCON. And starting with my presentation, first of all, I'd like to reflect all of you on 2 honest questions. How often has the thought of leaving this profession crossed your mind? And at the same time, how often have you think that you have achieved something worthwhile while doing this job in this specialty? Yes. So between these 2 emotions lies the reality of our specialty. I mean, as an anesthesiologist, we are expected to monitor our patient, their every breath, their every heart rate, and even every drop of blood. But my point here is, as an anesthesiologist, who is going to take care of us? So let's delve into my presentation. So burnout was first defined by psychologist Herbert Freudenberger in 1970s. WHO defines it as a syndrome resulting from chronic workplace stress that has been unsuccessfully managed. Burnout is not depression. It has core dimensions of emotional exertion, depersonalization, and reduced personal accomplishment. Though it is not depression, if unrecognized, it can progress to depression, which is why early identification and support are very crucial. So why this topic matters? This topic matters because the strength of anesthesia lies not only in the drugs and devices, but also on the clinician behind them. Burnout anesthesiologists will have reduced vigilance, difficult decision-making, and less situational awareness. This will increase the chance of medical error, compromising the quality of the care we provide to our patient. So when any anesthesiologist struggle, the system weakens. This will ultimately lead to reduction of our productivity, thus shrinking an already limited workforce. Coming to the epidemiology, it has been also described in the previous presentations as well. So the global incidence of burnout among anesthesiologists is 30 to 60%. In cases of Nepal, there are no studies done among anesthesiologists at the time of this presentation, but there are certain wave surveys done among healthcare workers of Nepal, and it has been found that 58.2% of healthcare workers of Nepal have experienced burnout during their lifetime experience. Also, the risk of burnout has increased in post-COVID era, and it is compared to have the highest risks of burnout in comparison to other specialties. And among the subspecialties of anesthesiology, chronic pain subspecialty is supposed to have the highest risks of burnout. So why the risks of burnout is highest in our subspecialty? We work in an environment that demands continuous vigilance, rapid decision-making, and zero tolerance for error. Even a brief lapse in attention can lead to life-threatening consequences. Our work is often isolated behind the drapes with long hours, night duties, and limited recognition despite high responsibility. When something happens, the first victim becomes the patient, but we become the second victim. Imagine the number of times we have replayed the case in our mind when something goes wrong. Also, the silent psychological trauma significantly contributes to our burnout. Also, over the time, there are various conflicts and between the systems and various constraints as resource constraint that will also lead to burnout. There are certain times when we have to stop the treatment of the patient just because of the financial constraint of the patient that will also lead to the emotional burnout to us. The very trait that defines excellence in anesthesia, sustained vigilance, becomes the mechanism of depletion. What protects the patient slowly exhausts us. So the hidden cost of vigilance comes into the different signals as motivational signals, as resignations, early retirement, disappointment, boredom, or affective signals as change of mood, emotional exertion. Similarly, physical signals as headache, nausea, dizziness, increased consumption of tobacco, disturbed sleep, or absenteeism, and certain cognitive signals as sense of failure, hopelessness, poor self-esteem, and inability to concentrate. Then the question arises, what drives this progression? So burnout arises from different interacting layers. First, there can be various contextual factors, as in cases of COVID-19 or high acuity environment, stress comorbid cases of ICUs or operation theaters. Workplace environments as long working hours, lack of peer support or lack of supports from the one who are on the leadership positions. Similarly, certain demographic factors as early age of the career or younger age groups are also expected to have higher degrees of burnout as per various studies. So, despite having such a high prevalence of burnout, why it goes unnoticed? It goes unnoticed because stoicism is rewarded in our culture. The culture encourages resilience and suppressing emotions, making vulnerability seems like a weakness. There is fear of stigma, of being judged, or facing negative career consequences if they admit burnout. The system is designed to detect the errors, but not the stress that clinicians or the treating physicians are facing. Chronic fatigue is normalized. Fatigue is often seen as a part of a job, making it difficult to recognize as a sign of burnout. So are there any measurement tools for burnout? So there are certain measurement tools for burnout as Maslach burnout inventory, which is one of the most validated tools, and then Copenhagen burnout inventory scale, single item burnout scale. But again, these all tools have their own limitations as all of them are the self-reported data, no universal cutoff values, and they measure only the symptoms but not the cause. Now let's get back to the time of COVID-19. So COVID-19 was a stress test for our specialty. The pandemic was not merely a crisis. It was a stress test for anesthesiology worldwide and not alone our country. It did not create burnout on itself. It exposed its baseline prevalence. Workload intensified and uncertainty increased. There were surge in ICU roles, there was ethical distress, there was resource scarcity, which led to long-term psychological impact. And it also showed the system gaps that were prevailing from the very beginning of the time. So our systems were designed to sustain clinicians under extreme stress. That led to burnout ultimately. Burnout is a system problem, and it is not a personal failure. There is workload versus workforce mismatch. So if the system demands to continuously work without providing any support, even the most resilient anesthesiology will eventually burn out. First, mismatch between workload and workforce. There is increased surgical volume, decreased anesthesia workforce. One anesthesiologist are bound to manage multiple high-risk cases. And as per the data published by NMC on March of 2023, the ratio between the general surgeon and anesthesiologist is 0.7. And this data does not include the surgeons as behind other surgeons as plastic surgeons, orthopedics, or as such. So this shows the disparity in anesthesiologists and surgeons. Similarly, staffing models and duty hours. There are frequent night duties, long operating hours, inadequate rest, and emotional exertions. Next one is leadership culture and psychological safety. We always have that fear of judgment to speak out about stress, errors, without being judged. When clinicians feel unable to speak, burnout remains hidden and unaddressed. The fourth one is administrative burden. Administrative burden behind management of the patients as documentations, medical legal concerns, and non-clinical tax burden. So this ultimately reduces time for patient care and professional satisfaction. So how can we enhance our individual well-being? First of all, we should all know that caring for ourselves is never self-indulgence. It is essential for safe anesthesia care. We can incorporate simple habits like proper sleep hygiene. We can express to our friends about the difficulties that we are going through. Structured debriefing of any difficult cases can be done. We can follow proper nutrition, and if needed, professional help should be sought. Now coming to the institutional and leadership solution, safe staffing must be done. Well-being must be integrated into patient safety framework, protected rest and post-call recovery. Similarly, non-punitive incident reporting and mentorship and peer support programs can help with decreasing the burnout incidents. Another one is leadership training for anesthesiologists. Now coming to the collaborative burnout prevention, as a department, the departmental responsibility should be of ensuring a supportive work environment. National anesthesia societies can advocate for anesthesiologist well-being, so mental health resources for providing confidential support, and policy-level recognition for integrating burnout into patient safety. So what we can learn from high-reliability organization? So there are these rules in aviation industry that any person who is on duty during the aviation should have at least the rest of 10 hours and at least sleep of 8 hours uninterrupted. So we can learn from them. And also in cases of military medicines abroad, they have similar rest period, but I cannot assure the military medicine rules in cases of Nepal since I belong to one of the paramilitary organizations. And there can also be, we can also learn the team control and shared responsibility from these high reliability organizations. So this FAR 11725 is the rest period rule of aviation industry. Now lastly, reframing the narrative, burning is no longer a wellness issue alone. It is a system and patient safety issue. A burnout workforce cannot sustain the safe systems. And the time to recognize, support, and act is now. Finally, I want to leave one question to all of you. Have you ever been felt that you are burnout and worked in silence? So if the answer is yes, even to few of us, I think the conversation is very urgent and you should talk about this, because the future of safe anesthesia does not depend only on how well we monitor our patients, but on how well we care for ourselves. Thank you. So these are my references. And just in case, if anybody of you wants to check out your burnout level, so this is the QR code for Maslach burnout inventory, which is one of the most validated questionnaire for the burnout. Thank you.
Thank you, Dr. Sova. Now, we'd like to welcome our second speaker. He is Dr. Rupak Bhattrai, and he is Associate Professor. Dr. Rupak Bhattrai, he is the head of the Department of Anesthesia from the Noble Medical College Teaching Hospital. He has 14 years of exemplary experience in perioperative medicine. He is in a respected leader role, and he has published more than 20 plus research articles and 2 book chapters, and he's interested in critical care as well as pain management. He'll be talking on the topic, the art of perioperative consent, counseling, and communication. Over to you, Dr. Rupak.
Thank you, Chairperson, for a wonderful introduction. So, the topic given to me for today's presentation is the art of perioperative consent, counseling, and communication. So this is very difficult things for as an anesthesiologist, because we have less time in counseling, or we have less time in communicating with the patients, but yet it is an important thing. So I have nothing to no conflict of interest on today's presentation, and I have nothing to disclose. So my main objective of today's presentation would be to review the legal and ethical foundation of anesthesia-informed consent, to master anesthesia-specific counseling techniques, to improve perioperative communications and risk disclosure, and to address common pitfalls and implement its practical solutions. So one of the important things you have to remember is that your pre-op visit is not a hurdle. It's your most powerful tool to build trust, modulate physiology, and improve its outcome. So why anesthesia consent matters? So consent is a process, and it is not a form. It is a cornerstone of trust, safety, and shared decision making. So that is why poor communication will lead to patient anxiety, dissatisfaction, complaints, and ultimately litigation. So one of the famous quotes that was published in British Journal of Anesthesia in 2009, which was given by J. Bolt, and it says that a mind is like a parachute. It best works when it is open. So similar applies when we talk about consent, communication, and counseling, where it should also be open, untangled, and clear, so that we can achieve a safe and empowered landing. So what are the core elements of anesthesia consent? It should be voluntary, it should be informed, capacity present should be there. So capacity present in context of consent means that the individuals has the ability, mental and legal ability, to weigh, to understand the information and make voluntary informed decision. So there are some of the disclosure that has to be included when we are doing, or when we are taking the anesthesia consent. And the most common disclosure that has to be made are what type of anesthesia you are going to provide to a patient, whether it is a general anesthesia or spinal or any other forms of anesthesia, that has to be disclosed. The common and the serious risk factors regarding that procedure, that has to be explained. If there are any alternative choices regarding the procedure itself, that has to be disclosed again. And what are their benefits and limitations it should also be disclosed while taking the anesthesia consent. So I've given some of the key disclosure over here. So these are just an example. So when you are talking about the general anesthesia, the chances of having the awareness, the chances of having a sore throat, the chances of having nausea, vomiting, or dental injuries, etc., has to be disclosed. If we are talking about spinal or the epidural, the chances of PDPH, nerve injury, hypertension, etc., should be disclosed. If it is under MAC or a sedation, the airway obstruction or oversedation should also be disclosed. And again, the next important thing you have to remember is that consent is an ongoing process. So effective anesthetic communication is not a soft skill. It is a core clinical skill that reduces perioperative anxiety, decreases anesthetic requirements, improves hemodynamic stability, and is primary defense against litigation. So the framework of communication, counseling, and consent, it can be demonstrated with the help of the 3 pillars. So these are the 3 pillars where the art of communication is the foundation of the pillar, the process of counseling is the journey of the pillar, and the ethics of consent is its outcome. So we'll be talking the first one, that is the art of communication, which is the foundation of one of the pillars. So the art of communication, basically setting a stage is important over here, where environment matters a lot. So that is why it should always be a private, quiet space where you sit down with the patient or patient party and make an eye contact with them. So who is generally present? The patient plus key family members, support persons, and always try to minimize interruptions while you are doing the communication process. So this can also be explained with the help of the 4 C's, where first C is the clear, where you use plain or a clear language. It should be concise, where you don't overwhelm. You stick to major or the key points. It should be complete, where you try to cover all the essential points, like what, why, how, risks, benefits, and its alternatives. It should be compassionate, where you try to acknowledge the emotions of the patient or the patient parties. So you can use a phrase like, this must be worrying for you, etc. The next important thing is the teach back and visual aids. So we all know that a picture is worth 1,000 words. So using a visual aids like anesthesia-specific brochures, risk pictograms, icon arrays, tablet-based risk calculators, and next important thing is that teach back and closing the loop is very much important over here. So whatever you have counseled or whatever you have communicated with the patients, so try to ask them what he or she has understood it regarding it. So that is very much important. So active listening and responding to emotions. So look for non-verbal cues, like if there are any fear or confusion to the patients. Use empathetic statements like, it sounds like you are most concerned about the recovery. That's very common worry. Let's talk about that specifically. And always make a pause and allow silence for questions. The next pillar is the process of counseling. And it is a journey, not an event. So there are multiple points where at the pre-anesthetic area, you gather the informations of the patients. At PAC visit, you discuss it. At the day of surgery, again, you reconfirm it. And at the post-operative recovery phase, you take a feedback from a patient. So discussing risks effectively, don't just list out, contextualize and personalize it. Like the most common risk is this. The risks most relevant to you, given your diabetes, is this. And always try to use the natural frequencies whenever needed, like about 2 or 3 people out of 100 might experience this. If there are any alternatives that has to be given to our patients, so two alternative has to be discussed with the patient party, and always try to frame it as a choice, not an ultimatum. The next pillar is the ethics of consent, where it should be a voluntariness, it should be free from coercion, that is, it should be free from threat. Capacity presence should be there, where the patient should have the ability to understand, retain, and weigh the information. The information taken should have adequate disclosure, and ultimately, understanding would be achieved, and that should be our ultimate goal. And always remember, the signature is merely the evidence, not proof of this. So there are some of the common barriers in anesthesia consent, and that can be due to a patient himself or herself, because the patient may be on high anxiety, sedation effects on comprehension. The providers may be the barrier, where they may be rushed out into a multiple pre-op clinics. There may be a multiple handoffs. The system may be a barrier itself, where last-minute changes or incomplete documentations may be the barrier. And if there are barriers, that will ultimately result in incomplete understanding, dissatisfaction, as well as claims. So what should be the best practice for anesthesia team? Early anesthesia consultation, ideally more than 24 hours before surgery should be there. There should be a structured pre-anesthetic evaluation plus consent discussion. It should be re-verify consent in the holding area on the day of surgery itself. You can take the help of the nurses or other paramedical staffs and use standardized scripts, checklist for high-risk cases. So these are some of the examples that I've given over here. In case 1, the elderly patient who is terrified for GA awareness. So how do you proceed this? You can give a detailed explanation with BIS monitoring reassurance to a patient, and that may lead to proceed the case calmly. The case 2, where there may be an urgent cesarean section, and we all know that while we are performing urgent cesarean sections, there may be an inadequate counseling to a patient or patient party. And ultimately, what will happen? There may be a post-operative regret as well as complaint. Case 3, if there are language barrier for complex cardiac cases, you can take the help of the visual aids, or you can take the help of the certified interpreter, where full understanding would be achieved. So my conclusion for today's presentations would be, consent, it is a continuous conversation, not a paperwork. Excellent counseling reduces anxiety and improves satisfaction. Clear risk disclosure plus empathy is the best defense against claim. And when we make these small changes in our practice, that will have a big impact on patient experience. So I'll be leaving with the famous quote by Francis W.P. Body, which says that the secret of care of the patient is in caring for the patient. So mastering this art will reduce anxiety, builds unwavering trust, improves outcomes, and protect both the patients and the professional. These are my references. Thank you.
Now we have the third speaker. I welcome Dr. Vatsalya Aryal. She is associate professor. I know. He is associate professor at the Department of Anesthesia and Critical Care at Birat Medical College and Teaching Hospital. He has more than 9 years of dedicated experience in anesthesia and critical care, and more than 20 publications in national and international journals. His key interests are in critical care, POCUS, mechanical ventilation, and soft skills in ICU. Now over to you, Dr. Vatsalya.
Thank you, chairpersons, for this wonderful introduction. I would like to take this opportunity to thank the committee for giving me this presentation. I would also like to congratulate Pokhara team for organizing this wonderful conference. So moving on, my topic is perioperative infection control and responsibilities of the anesthesiologist. So I have no conflict of interest. I want to disclose that I am the director of Virat Medical Simulation Foundation. So hospital-acquired infection occur in 1 in 31 patients, 3% of the hospitalized patients. 7 out of 100 in high-income countries, 15 out of 100 in low to middle-income countries, 1 in every 10 affected patients. This data was retrieved from 2018 from World Health Organization. In the year 2022, the rate of SSI in low and middle-income countries was around 11% on average, ranging from 1.2 to 23.6%. This 3 to 5 times higher than the developed countries. And it is the most common hospital-acquired infection in low middle-income countries. The global incidence was reported to be around 2.5% in the year 2023. When the data was being retrieved from the year 1996 to 2001, the incidence was about 2.9%, and from 1996 to 2018 was around 2.2%. This decreased incidence was because of the recent development in medical procedures, introduction of less invasive surgeries, quicker mobilizations, improves security of patient immune system, and reduction in use of central venous catheters for parenteral nutrition. So from the different studies that were conducted all over Nepal, the range of SSI was noted to be around 2.3 to 2.9%. So why are we so worried about it? Because of the burden it causes, the prolonged hospital stay, increases the cost of healthcare, the morbidity, and the mortality. When we talk about perioperative infection, all we can think about generally is the pre-operative antibiotics, which is given 60 minutes prior to infection. But it is not limited to that. Because when a study was conducted with 100% compliance with prophylactic antibiotic protocols, nearly more than 5% developed surgical site infection. So it goes way beyond that. So this is a meme that is been circulated over the social media, and most surgeons really think what we do as anesthesiologists is sit on a chair with a mobile in our hands. It is not really that. So this figure displays there are different times anesthesiologist interacts with the patient and all the environment around. The red markers showing the frequency of an anesthesiologist, whereas others, black is for surgery nurse, and blue is for the surgeons. So it's basically the hands. Most major factor is the hands. Because if we are very hands-on with the patient and high level of task density, it has been recommended by WHO that more than 300 times per hour should be the frequency of hand washing in the anesthesiologist. And this increased hand adherence will significantly correlate with lower incidence of healthcare-associated infections. It's not that. Also, the other factor is improved intravascular catheter handling. Generally, when we think of intravascular catheter handling, we only think about at the time of insertion of the catheter. But there are other points as well, because after the insertion, when we try to give the drug, if we clean the stopcock with the disinfection, it has shown to decrease the SSI rates. The use of wearable alcohol-based rubs dispenser has shown to decrease the contamination risk because of easy accessibility you can increase the compliance with the hand hygiene. The other point is operative environment. So we need to keep the dirty areas and clean areas in the separate areas. For the dirty areas, should be on the right side of the provider, the anesthetic machines, the monitor screens, storage of contaminated airway instruments like laryngoscope blades and handles. On the left side, we need to clean the clean part, where IV stock sits, all the medical syringes, anesthesia supplies, and medication charts. Card. So once you have induced anesthesia and stabilized the patient, we need to wipe down with the stethoscope, anesthesia machines, computer, and ventilation bags with disinfection wipes. Use of the multi-dose vials should be limited. You should use the closed lumen IV sets and surface disinfection of the operating room between the operative cases and during the end of the day in the terminal end. Pre-operative patient colonization should be done. There is use of 2% chlorhexidine gluconate wipes to the entire body. Use of 0.2% chlorhexidine gluconate for oral mouthwash. Use of intranasal povidone iodine or mipirocin treatment. Perioperative thermoregulation. Even the mild perioperative hypothermia, that is around 2% below the normal core body temperature, increases the wound rate, infection rate, it delays the wound healing, lengthen the hospital stay. So it is recommended to monitor core body temperature for all the surgical procedures for cases longer than 45 minutes. There are certain supporting evidence, less certain interventions, but some supporting evidence where you need to control the sugar, goal-directed fluid management, and avoid hyperoxia. All these put together, we need to generate a surgical care bundle, which effectiveness has been shown to prevent the spread of infection and improve the perioperative patient safety. We may think that it may not be possible, but there was a study that was conducted on the feasibility of this bundle on 23 operating rooms in large teaching hospitals. A total of 800 surgical patients were checked. And the study was done before 3.5 months before the implication of the care bundle and after the 4.5 months. And it is shown that the effectivity and feasibility was adequate, and it helped in reducing the SSI. And the most important thing is we need to be the leaders, we as an anesthesiologist. Because anesthesiology is considered to be a dynamic medical specialty. Its professional practice focuses on comprehensive care and safety of the patient. The prevention and control of hospital-acquired infection is one of the key pillars for ideal anesthetic practice. The anesthetic team can become the infection control pioneers within the hospital, but in order to be successful, structural and organizational resources in training, personnel, and material and time must be adequate. Anesthesiologists are well positioned as leaders in patient safety to reduce perioperative bacterial contamination. Steps should be taken to utilize the evidence-based tools and guidelines for perioperative improvement. So the take-home message, be the leaders. Start from the front. Follow the infection control bundle, which will include perioperative antibiotics, improved hand hygiene compliance, intravascular catheter design and handling, improved environmental cleaning, perioperative patient colonization, and perioperative thermoregulation. Thank you.
Thank you, Dr. Vatsalya, for the wonderful presentation, and I'd like to call all the speakers forward and we'll have a question and answer session. So from the audience, if you have any questions, please raise your hands.
Thank you, speakers. Myself, I am Dr. Lalit from Viratnagar. My question is for Dr. Sova. Actually, this was a very nice, wonderful presentation. I was really splendid, bonded by your presentation. One thing, as a person, we have the screening tools for noticing burnout in ourselves. But the screening tools, they give you a number. As for a person, there is a personal variability is there. So some stress I may be tolerating, the other person may not be tolerating. So is there any other way you can early predict the burnout so that before your exhaustion starts, you detect it and take some prophylactic actions? This is one question. The second question is, we are now the leaders. We take care of the teams. So how you are going to take care the burnout issues in your team as a leader?
Thank you for your question and thank you for your generous and kind words, Lalit sir. And the first question is how do we address having different levels of burnout as per different level of stress, right? I think the best version of us is ourselves, and we know ourselves very well in comparison to others. So I think the initiation should be started from us ourselves. So if we experience some kind of feelings that may lead to burnout, or we are having some kind of feelings, then it's better to share with someone who we can share without the fear of being judged. It may be in your family members, maybe in your team as well. So I think that will help. And for the second questions, as a team leader, I mean, by the time you are a team leader, then it should have been some years or some time that you are dealing with your team members. So you know how different members will react in different things, and how what they are up to or what will matter them. So again, the dealing with the different team members will be different. Like sometimes rewarding someone will help, and in sometimes strict rules and regulation may help someone. So I think dealing with the team members as a team leaders, differentiate with the type of the team members that you are dealing, but then you should go to the ground levels, understand their level of perception, and then you can work on the burnout or the incidents as such happening. Thank you.
Some questionnaires for our team members, which can be audited every 3 monthly or monthly, so that if the answers are related to the burnout, then we can work on the team as well.
Okay, I'll add something. So there are lots of meditations and yogas that are available these days. So I think in between our work, 10 minutes of meditation or 10 minutes of some yogas or other forms of these things may also add to your, to decrease the burnout process. So I think that should also be tried. Thank you.
Dr. Ritu.
Yeah, thank you, chairpersons. Thank you all the three speakers for the wonderful session, because last but not the least, these are the very important sessions which has been covered in this scientific session. My question is to Dr. Rupak, and myself is Dr. Ritu. I work in Bir Hospital, and I'm very much interested in this type of peer-to-peer consent, counseling, and communication. And I'd like to ask, because have you any experience of facing challenges or difficulty by taking a separate consent from anesthesia side, and have you make any changes in the tricks in your institute to establish a separate anesthesia consent? Thank you.
Thank you. Basically, we have now we have tried to make our pre-anesthetic clinic more advanced than what we were following, isn't it? So what we can do is that we can give a full phases PEC room, which can add like you can give up 10 to 15 minutes of counseling or communicating with the patients. So that may decrease these litigation process later on or any sort of complications to a patient. I think I have not experienced that sort of challenges. What you were trying to ask. I think I have not seen any challenges that has been.
My curiosity is on have you.
So you are talking about anesthesia consent form.
Separate consent form. Do you,
No, we don't have a separate consent form at present, but we are using the same PHC form where the last portion of it, we take a consent to a patient's. That portion has been added, but we don't have a separate consent form for anesthesia.
Yeah, thank you. Because as far as I remember, the Society of Anesthesiologists of Nepal have delivered a consent form and sent us in our email, life members' email. And when I go through it, the consent form has been very long. And I feel it's very, even though it's endorsed in the society, we felt all our department faculties feel we need to revise it and contextualize according to our institution. So I was very curious if you has made any changes or not.
No, we haven't made yet.
Thank you.
I would like to add, ma'am. Just recently, around a month back, I, as an anesthesiologist in my department, I started doing it. Actually, I made a consent form where I've included all the points from the consent form of SAN in a box shape, so that it doesn't look big. It is in 2 pages, both sides. We can do that. It's not difficult though. But in SAN, it is lots of things are there. I've seen that consent form. I've taken all the things from that, try to conceptualize and make it comprehensive. And in a table format, I've made that form. We are using that form right now.
So their patients are
they are comfortable. Generally during the PAC, I'm in the Virat Nursing Home. I've started around a month back, but it's been, I think, around a year or so in Virat Medical College, they have been using it. So we fill it during the PAC, when they are doing the PAC forms, we'll fill up the forms. The consent form is taken at that very time, including the type of anesthesia you are going to do. And they tick it and then try to explain all the complications, what are the benefits. Similar to the one that is made by SAN, but a little more comprehensive.
Thank you for that. Thank you, Susan.
So regarding this consent, the form, so yes, we all know that SAN has developed this very beautiful, the consent forms. But the thing is, we need to keep in mind that, so whenever you read out all those things that is written in the consent book and talk to the patients, and some of the things they might not be understanding, and it doesn't look, it goes in a different way. So basically the principle is, talk to the patient, have a good communication. So basically it is the art of communication, art of counseling, and take the patient in your confidence. Then once you do this, a proper counseling communication, later on you can record for documentation whatever way you want. So just by making the consent form is not good enough. You need to learn how to communicate, how to talk to the patient, how to take the confidence of the patient. I think that does matter more than taking the notes. Thank you.
So are there any more questions or comments? I have a question for Dr. Vatsalya. So you said that we use 2% chlorhexidine for, painting purpose. So are you routinely using it? Body wash.
For body wash before the surgery. No, we don't use it in our institute. It's recommended.
Are you practicing that?
No, ma'am, no, we're not practicing it.
Okay.
We're using soap water. Just we'll ask the patient to take a bath.
Take a bath. Okay, so it's not that you're...
It's just the guidelines, Sam.
Okay. Thank you so much, all the speakers. Dr. Soba, you did it very well. And though we do not have any guidelines on how much of our time we give to our clinical practice. Our residents here, they know they've been working day and night, and some of our consultants and even us, we are 24/7 on duty. So there is some form of burnout in all of us. So most of the time we talk about patient safety, and it's high time we talk about our safety also. So it was a very wonderful presentation. Congratulations on that. Dr. Rupak, you talked about the art of perioperative consent, counseling, and communication. It was very well done. And sometimes we take it for granted. And most of the time, we don't communicate with our patients so well. And for example, most of the patients from who are undergoing surgery, they'll come to us and ask about the procedures. I face so many patients who will come to me and ask about the procedure. So I'm not trying to tell that the surgeons are poor communicator, but still, when you communicate with we all have our own responsibility. So surgeons should tell the patients about the surgical procedure, and we should be talking about the anesthesia thing. So here also, we have a certain breach in communication. So it happens all of the time because we are working in a very stressful situation with time pressure and all. So that should be considered for all of us to take away. And that's it. I think we are in a leadership role, and I think most of the time we see that when we have a junior resident or colleagues who have a problem, and we intervene quickly without taking care that we are following proper IP. So most of the time we'll have surgeons intervening without wearing a gown and proper attire, and even our anesthesia colleagues intervening without any proper hand washing and scrubbing. So we should take away that we all are interested in patient safety. So we all should practice proper IP measures. And we should also empower our nurses. They are very good at, saying that, oh, doctor, do this or do that. So we should empower our colleagues, our nurses, to tell us when we are doing wrong. So that'll also help our patients. Thank you so much.
Thank you, all the presenters. You've done a wonderful job. And sitting here with 30 years of experience in anesthesia, in medical practice, and practice in anesthesia for 25 years, we have always, I think our generation always had been, working. We never thought of ourselves. We never thought of for the well-being of us. And we always had our priority for the patients, for the government, for the system, and all those things. Now I think with your presentation, you have given us the insight and the thought, that you all are very pragmatic, and you all can speak out. And then I'm sure you all are in the leadership role, in the organization. And I congratulate and best of luck. You should work for the betterment of our medical colleagues, our doctors, our juniors, and as Dr. Rohini rightly said, our juniors, our subordinates. I think we should take care of them also. And we should always speak out, and then we should say what is right and what is wrong, and then together we'll move for better anesthesia and for better humanity. I think with this we can, do we have anything more from anybody else? So now I think we've had a very interactive and a very nice session, and it's the last session, so I think we'll round up with this. Thank you for having us, and thank you for your time.
I'd like to request the chairpersons and the speakers to stay on the stage for the photo. A very realistic and inspiring presentations from the speakers. Thank you so much, sirs and ma'am, for your presentation. We move towards the end of the ceremony, and we'd like to bring the session to an end. And I believe this session of perioperative care leaves everyone with food for thought and hits the right notes concerning burnout, patient safety, and counseling. What my take-home message was, take care of yourselves, take care of your patient, and take care of your work environment. Thank you. Now we'd like to conclude the session and request everyone to join us in Hall A for the final closing ceremony. Thank you, everyone.